Hi everyone, I'm Professor Sarah Rankin and I would like to welcome you to Imperial COVID-19 lockdown lessons. Today is lesson 11 and we are actually joined today by 3 doctors. All these doctors have been working in hospitals in West London during lockdown, but normally they would spend their time, some of it in hospitals and some of it doing research in laboratories. So we have Margarita here as always, and she will be looking out for your questions in the chat. So please post any questions in the chat on YouTube as we go along. So first of all, we're going to start with Dr. Jamilah Meghji, who is going to be telling us about how the NHS had to rapidly change in response to the pandemic and how that was done on the ground, as it were. So I'm going to pass you on to Jamilah now. Thank you, Jamilah.
Thanks very much, Sarah. So thanks for having me on to speak. So as Sarah said, my name's Jamilah Meghji. I'm a respiratory registrar at St Mary's Hospital. And today, if I can get the slides to move. Yeah, so I'm just going to be talking a little bit firstly about my career path and what I do, and then I'm just going to talk a little bit about some of the challenges we faced clinically as doctors during COVID, including the uncertainty of dealing with a new disease, which we didn't recognise, the difficulty of working in health systems which were changing and operating in different ways, and the challenge of working in a system that's constantly changing. And then I'm going to end by just mentioning some of the opportunities that I think have sort of arisen from everything that's happened in the past few months. So firstly, me. This is my career pathway, and the orange bits are the bits that are a little bit different from the conventional pathway, I guess. So I did my A-levels and my preclinical medical training, and as part of my training, I did a year of social anthropology. And I'd really encourage anyone to do a bit of humanities or social sciences along the way. It was great. I then did some clinical medicine and my clinical medical training, and did 2 years of foundation year work as a junior doctor. Before realising that I was really interested in the upstream causes of ill health, as well as what it is to be a doctor and deal with the problem of poor health itself. And so I went off and did a master's in public health. I then came back and did another set of sort of clinical work years, and got a place as a respiratory registrar. But I knew I wanted to do research, preferably in a low-income setting, and so I took 6 months to go and try being a research fellow in Malawi and Zimbabwe. Came back for a bit and then applied for my PhD, which I did between Liverpool, and I spent 2.5 years living in Malawi doing that. Came back to the UK in 2018, and now I do a mixture of clinical and academic work. So that's me. So to start with, I just wanted to talk a little bit about the difficulty of dealing with a new disease in clinical medicine. And I guess what we do in clinical medicine is a lot about pattern recognition. So we're presented with something, a problem, a patient. We do a little bit of listening, a little bit of looking, some measuring. And after we've done those things, we recognise, hopefully, the pattern that we're dealing with, and then we know sort of what to do about it. And there are, over the course of your training, what you're really doing is getting better and better at pattern recognition, both recognising things that are different from each other, and also identifying things when they're just variation of the same sort of broad pattern. But there are patterns that we're very good at dealing with, and these are some of them. We recognise them very quickly, really. And those things are things like pneumonia, for example. We know when someone comes in with a cough, a fever, producing sputum, and we see this pattern on an X-ray, we can recognise pneumonia and treat it appropriately. With things like heart attacks, we recognise the pattern of chest pain that patients might describe when they come into hospital, and we know that the appropriate test is an ECG. We know how to interpret it, and then we can treat it. And the same with broken bones. You know, an experienced A&E doctor will be able to hear a history, look at an arm, have a guess at what the fracture is, and then go on to treat it. But the problem, of course, with COVID was that it was an entirely new pattern and none of us really had seen it before. We didn't know what it was. And so we had lots of questions. We didn't really know who gets it, how they get it, how does it affect them, what's the underlying cause, how would we diagnose it, what would happen to patients who had it, and then how would we treat it and prevent it. All of those things were unknown. And I think really when I was thinking about our response to COVID, I was thinking back for examples of previous new patterns that we've seen in medicine before, to understand how we dealt with that. And really for me, one of the things that comes out really is HIV. So in the 1980s, HIV and AIDS were really a new condition, and there was this flurry of patients coming into hospitals, really sick, and no one had seen these sorts of patterns of disease before. It was a new thing. All we knew really that it was homosexual men, haemophiliacs, IV drug users, and they'd come in with a lot of weight loss, bad x-rays, a lot of rashes in their mouth and their skin, and that eventually they would die. And it was really scary for doctors, nothing to do really apart from hold the hand of their patients and walk with them as they went through this. But of course, over the years, things have changed a lot. So we now understand it's a virus, it's transmitted through body fluids. We have diagnostic tests, blood tests, finger prick tests, oral swab tests. We have drug treatments that mean that it's now a chronic disease. And we've understood more and more about how to prevent it. We're not there yet, but we're getting there. And I think actually there are a lot of parallels with our response to COVID. So I think we should be grateful to the Chinese because they did a lot of the early work in pattern recognition. And when this started in Wuhan, it was a new condition, adults more than children, terrible x-rays or with very low oxygen levels, and a lot of people doing really badly and dying. So it looked different to a normal pneumonia. And of course, since then, again, we've made a lot of progress. So we know that it's more in adults than children, and that it can affect anyone all over the world. We know that it's transmitted in respiratory droplets and it's a virus that's causing it. We know that as well as affecting the lungs, it can affect the blood vessels and cause a lot of inflammation in the body, and you can pick up characteristic pictures of that in the blood tests. We have diagnostic tests with swabs. Those aren't perfect yet, so we're still using the clinical pattern to recognise it, but we're getting there. And we're beginning to understand what the risk factors for doing badly are, things like age, obesity, diabetes, high blood pressure. So we're getting there. There's still a long way to go. We don't really understand the long-term outcomes of patients with COVID or how to treat it or prevent it. But from a period of time a few months ago where we really didn't recognise the pattern at all, I think we've come a long way, and we're beginning to recognise it and be able to diagnose it clinically when we see it. But of course, as well as all of that clinical uncertainty, there was a lot of uncertainty in terms of how we should be dealing with patients. How do we get them through the health system? And usually in medicine, we're creatures of habit. We like to follow pathways with our patients. And in normal times, if you had a chest infection, you would go to your GP. Your GP would recognise the pattern of a chest infection or a pneumonia. They would send you to A&E. You'd have some tests. You might get treated with oxygen and antibiotics and be put on a ward. You might go to intensive care if you were sick, go to rehabilitation, and then you go home. And that was a sort of standard pathway. But in COVID times, that was all disrupted as well. So GPs weren't able to see patients because of the infection risk. A&Es were very busy and having to separate COVID and non-COVID patients. Some of the tests that we usually do, we couldn't do as easily because of infection risks. And the same was true for some of the treatments that we use for breathing problems. The wards were complicated because we were having to split patients up. Intensive care was incredibly busy. And the number of physios and rehabilitation placements we had was also limited. And even going home was complicated because what if your home was a nursing home? How would we get you back there safely? That was complicated. And when we think about health systems, in general, this is a model that the World Health Organization, the WHO, have sort of set up when they think about what it is, what components you need to have a functioning health system. And actually, our experience of coronavirus really threatened or sort of challenged each of those components. So We've talked a bit about service delivery and patient pathways. There were difficulties of staffing, not only for doctors and nurses, but also for cleaners, for porters, for physios, everyone who makes up our team. We had problems accessing technologies and medication. You know, there were issues around enough oxygen or access to ventilators. There were questions about who's going to pay for all of this, who's going to lead the service, who's going to lead the departments, the hospitals, and then how do we communicate between hospitals and GPs and patients and families to make sure things run smoothly. So incredibly challenging to have that health system uncertainty on top of clinical uncertainty. Now, I Googled books about change because I was thinking, oh, you know, there must be some books about managing change, and you get hundreds and hundreds of hits, and this is just an example. And the reason for that is because change is, of course, really difficult. And as clinicians, we were operating in an environment where things were constantly changing. And I think the honest answer is that a lot of us feel a bit like this right now. It's been a difficult few months coping with all of that change. But as Einstein says, in the middle of difficulty lies opportunity, and I think that's certainly true here. I think we've learned a lot. We have learned to work together better because we've had to. And I think that's been, hopefully that will be something that will last going forward. We've learned new skills. A lot of doctors and nurses were put in different clinical environments where they had to work with different colleagues and learn how to use different techniques, different technologies. That's been incredibly productive, I think. We found new ways of working. So a lot of our clinics have moved to telephone clinics instead of in-person clinics. And I think a lot of patients would like that to continue. It's much more convenient for them. So that may last. I think a lot of us have been involved in processes of science and scientific discovery, and that's exciting, and it means that we've been able to contribute little jigsaw pieces to understanding what COVID is, and it's really quite a privilege, I guess, to be involved in that. And then I think the last thing is that I think we, as a country and as a NHS community, have really learned to sort of revalue the NHS for what it is. It's quite a remarkable thing to be able to deliver healthcare to people no matter what their background, and I think it's a really helpful reminder of that. So that's me really, challenges and opportunities as a clinician during COVID.
Thank you, Jamilah. That was really insightful, and it's really good to have that sort of overview of the health system and how it all sort of fits together. And obviously, it's all, you know, dependent on different things. You know, you mentioned finances, and that's a huge thing that obviously the NHS has been under pressure for many years for what we would consider being underfinanced. And also the point you make about change. All those books, all great, but you know, who had time to read books? You know, because the thing about, you know, the whole you know, our response as a country, individuals, etc., to this pandemic is the speed at which people had to change. And there are a lot of people that are resistant to change. You know, a lot of people would like to debate for, you know, be in hundreds of meetings to discuss when they're going to change even the smallest thing. So the fact that we had to change on this sort of monumental scale overnight, and all our sort of, you know, practices at home and at work was quite phenomenal. But it shows that you can do it. Yeah. And I think that's in some ways a very positive message, because there are a lot of things we would like to change. I mean, I'm sort of very big in terms of, you know, diversity and equality and things like that. And, you know, people always sort of suggest, oh, this is going to take time, blah, blah, blah. But actually, no, it doesn't need to. You can accelerate change, and that can be a sort of positive thing. So I think, yeah, lots of positive things will come out of this. And it's deciding which of those we retain and which of those things we don't want to. So thank you for that. I'm sure we're going to get some questions. We're now going to I think Chloe is now going to talk to us, and she's going to be talking from her perspective. So Chloe was a respiratory physician, and but as I say, she normally sort of spends quite a bit of her time in the lab at the moment, but she went back onto the wards and had a particular job that she's going to tell us about, and tell us about what it was like as a respiratory physician or on those wards, actually dealing with the patients that had COVID-19. Thanks, Chloe.
Thanks. Hi. Thank you for inviting me along today. So, oh, not sure I've got the control. Yeah, so we've heard a lot about different ways and some of the lockdown lessons of entering into science, and Jamilah's talked about how she came into clinical medicine and research. So I just wanted to briefly touch on how I came, again, a different route. So I did standard science A-levels, then I went to medical school in Manchester. I took a year out to do some more science because I really enjoyed it, and came down to Imperial College. And then I started my clinical training in London. So I worked in lots of different London hospitals, as you tend to do in your medical training. You typically will work in some teaching hospitals and also some more local district general hospitals to get a really good feel of how everyone does everything. And then one of the things that's fantastic about medicine is you often get the opportunity to work abroad. So I worked in Australia in an intensive care unit for a year, which was, I had a brilliant time there. And then I came back to London, worked in more hospitals. And by that point, I really knew that I had really enjoyed doing science. So I went and did a PhD. And my PhD was in genomic data and immunology. And by this point, I knew I was very interested in respiratory diseases. So I worked on the disease tuberculosis. And then at the end of my clinical training, I wasn't sure what to do. I really enjoyed clinical training, but I also really enjoyed research. And so I did another degree. I did an MSc in epidemiology. And at the time, I was also on maternity leave. So I was very lucky. I got to do a distance learning course, which now that seems that's what everyone's doing. But at the time that was fairly novel. A lot of people told me not to do it. It wouldn't be very good. And in fact, it was the complete opposite. It was an amazing course. I still use the resources from then now. And I think distance learning worked really well. So the reason why I did epidemiology is that's because we try to look at the causes of health outcomes and diseases at a population level. So you sort of see the bigger picture, which I was interested in. I did a year of research and then realised I really missed clinical medicine. So I now do both clinical medicine research, but predominantly research. So then I'm just going to talk about what I did during COVID-19. I'm having some problem. Okay, so these are the sort of four main things I did. The first thing was the family liaison service, which I'll talk about. I also helped man the COVID-19 respiratory advice line. And as Jamilah said, all our clinics were converted to telephone only. And I did quite a bit on COVID-19 research, and I'm still doing that now. So that's quite a chunk of my work. So I'm just going to talk about the family liaison service. Having some issues with, okay. So as most of you will know, that families were not allowed to visit their loved ones who went into hospital. And, you know, that's a huge worry. Even normally, if your brother or your father or your mother goes into hospital, you really want to go and see them, and they couldn't. And that was made worse by the fact that most people were going to hospital with COVID-19. And of course, there was great worrying concern about what would happen to them. And then on top of that, the hospital staff who could potentially have phoned all these families to tell them about that were immensely busy. And many of them, to use the phone, would have to remove all their protective wear, remove all the PPE to do this. So, you know, a lot of families had absolutely nothing about their loved ones. So the family liaison service was set up to ring families every day to let them know. And of course, this offers assurance to the families and friends. It was only possible with some of the larger hospitals, and the Royal Brompton Hospital, where I was working at, was one of the first to do this. So you can see here, the top picture is one of the doctors who was at this point was phoning around some of the families. And the other picture is of a physiotherapist who normally worked in intensive care, and then on her days off she would help with the family liaison service. So a lot of us in it were doing this as voluntary. To do the service, you needed to have good intensive care knowledge, because it's very complicated what happens to patients in intensive care. A lot of, some people just have one organ that doesn't work, their lungs, but often people had several organs that weren't working. So you had to understand what was happening to them. And you also had to have the ability to be able to talk to the relatives and explain exactly what it was that happened, and be able to say it to them in terms that they would understand. So the team consisted of people who worked in intensive care normally, the doctors, the nurses, physiotherapists, but also cardiologists and respiratory doctors, because we have quite a lot of interaction with intensive care in our day-to-day job. I have to say the phone calls were very tough, often quite emotional. It could be quite long, and they could be quite difficult, but were incredibly rewarding. And one of the skills really was to gauge how much the families understood. There's different levels of understanding with every single family you spoke to, and also how much information they wanted to know. Intensive care involves a lot of numbers, numbers about your heart, numbers about the lungs, but you had to really, try and gauge what it was that they knew, and we'd pass this information on to each other. So we were had a good team between us, and making sure that the families were kept up to date and in an appropriate way. Initially as well, on the intensive care were patients who didn't have COVID-19, but as it got worse, the units, so several units, they were all completely filled with people with COVID-19. And we tried to do other things, such as facilitating video calls, which meant that we would try to help families ring and see their loved one. But of course, you really had to explain to them what they would look like, because a patient in ITU doesn't look like your normal loved one. They may have tubes in them, they may be sedated. So these sorts of things we had to think about. We'd also send in photographs and have a board next to them, so that the families really felt like they were doing as much as they could. And then we offered other things such as psychological support and spiritual support. So I just want to talk about one of the things that they offered in the Royal Brompton Hospital. It's a specialist lung and heart hospital, so they're able to offer ECMO, which is extracorporeal membrane oxygenation. Now this is very unique, and what ECMO does is it gives the lungs a rest. So the patient's lungs were really fighting hard against the COVID-19. So this was the opportunity to allow them to fight against it with putting them on this ECMO machine. So you take them the blood out from a large vein in their neck, and then pass it through an artificial lung outside the body. Now this lung can add in oxygen and remove the waste carbon dioxide, and then pass the blood back through to the body. And it's very similar to a machine that you may know that's used for cardiac bypass surgery. But one of the complications was, because you've got blood passing through tubes and the artificial lung, it could potentially clot. So the blood, we had to give them blood thinning agents continuously. But then, of course, there's a problem with the risk of bleeding. And both clotting and bleeding were already issues with COVID-19. And so continuously, the doctors were learning every day how to manage these issues and what to do. So this is a picture of a patient who's having ECMO, and also, just showing how many machines are involved in intensive care. And just as I said earlier, during the peak of COVID-19, every single ITU bed was full of COVID-19 patients, which meant that the other patients, the adults and even children, had to be moved to different intensive care units. And to get enough ECMO machines, they were getting bits and parts from all over the country. And to do this, to manage this, requires real expert knowledge. So the physicians, the nurses were working incredibly hard to look after all these patients. They've never had as many patients on ECMO, and hopefully never will again, but that they were able to do this. And one of the things they would do, because this is what's called a tertiary referral centre, so the doctors would go out to other hospitals, other intensive care units, and see patients that may be suitable for ECMO, and then they would have to transfer them back. So it's a totally specialist service that they're offering. But then, of course, because of this, they're actually needing a very long time intensive care unit, 3-4 weeks just on the ECMO, and then they'd have to come off. And then they'd have to have a very long recovery period. So some other things that I did during the period was because initially everyone was, immediately didn't want to have face-to-face care, sensibly so, but this also meant that a lot of people out there who had respiratory lung problems, so particularly asthma, were then very worried about their asthma. So one of the things I did was to write an information sheet that was readable by the people who had asthma themselves, to try and encourage people to look after their own asthma, to empower people. And this got really taken on, and I had a lot of people contacting me from my local community, and eventually some community pharmacists found out about it, and it's now been put on pharmacies throughout the UK, so that people know how to optimise their asthma medication. Our clinics, as we said, were cancelled because we didn't want to see face-to-face, and also we were all involved in COVID-19 work. But after some time, we converted these to telephone clinics. And this was something actually that's been advocated within the respiratory community for quite a long time, but we've not really done it. And as Jamilah said, for many patients, this works extremely well. The GPs themselves set up these COVID-19 hot hubs. So patients who are worried that they had it could come in, be assessed, their symptoms, and have a swab. So alongside this, we ran the COVID-19 respiratory hotline. So we were answering calls from GPs who were, worried about their patients. Where should they do? We were kind of triaging them. Should they go to these hot hubs? Should they go to A&E? Could they stay at home? And this was a, rapid, urgent advice service we were providing. But I just want to talk about also some unexpected things that happened. Some unexpected pattern was that people with respiratory diseases, so asthma and something called COPD, which is a smoking-related lung disease, they seem to have less problems with less asthma attacks and less breathing attacks. Now, this could be for several reasons. The first being that people with lung conditions seem to comply with their medications more than usual. And we knew that because some of the stocks of inhalers, the inhaled medication they use, ran low across the UK. Air pollution, of course, was greatly reduced, and that can be a trigger. People started shielding, even if they weren't told it by their doctor, but they were shielding, which meant they're avoiding all viruses, not just the SARS-CoV-2, but any virus that normally might trigger their breathing problems. And lastly, people were scared to go to their doctor or their hospital. So it may be that they were still having these breathing attacks, but they were just learning to manage them at home, which, often this wasn't safe, and they're presenting late to hospital. And another unexpected thing happened, an unexpected outcome, was that people with asthma seem to have less severe COVID-19. And we knew this from data from China and Italy and the US, but this didn't really make sense because you'd expect people with asthma to be more susceptible to a virus that affects the lungs. And we'd certainly seen that before in flu pandemics. So we needed research to understand if asthma is protective, and if it is, why is it protective? So this is something that I've been working on. And I'm still working on. And because I'm working in epidemiology, one of the things we like to do is look at as much data as possible. So we use big clinical data. So I'm doing a project where I'm looking at 1 million people with asthma across the UK and using statistics and epidemiological methods to see, are people with asthma more protected? And if they are, what are the factors that seem to be protected? So this work is ongoing, but hopefully it won't be too long before I'm able to share this results with everyone. Thank you.
Wow, that is fascinating, and huge amount of work you've been doing, Chloe. I mean, it's incredible. So, God, I've got so many questions, but I'm going to leave those to our audience, and we'll go straight on to Rasha. So Rasha is also one of these amazing people that are not only doctors, but they're also scientists. So they work sort of in the hospital and as a scientist as well. She's a cardiologist, so this is slightly different. So we're going from the lungs, and now we're going to hear the perspective of cardiologists, because clearly people were still having heart attacks and things. So how do you, how are you able to actually serve those people as well? So over to you, Rasha. Oh, Rasha, you need to turn your mic on.
Sorry, classic. Thank you so much, Prof. Rankin. So I guess from my point of view, the difference for me is that I wasn't as much acutely involved with COVID-19 patients sitting on wards and as the respiratory team and the intensive care team were doing. But we did see a lot of COVID-19 within our cardiology patients, and of course much of our service had to change because there was no longer space for these respiratory patients just on respiratory wards, and so many of us cardiologists had to turn our hand to a bit more respiratory support. Let me tell you a little bit about myself. So I was born in 1978 in Liverpool. These are my parents who came over from Iraq to study as academics over here. Always thought they'd go home, but actually stayed here forever since. I went on to study at Oxford University for my preclinical, and then did my BSc year there, and then came to study and do clinical medicine at University College London. In terms of my career path, I've kind of focused on my cardiology career path here. You can see that I started as a cardiology house officer at the Heart Hospital, as it was then, and at that point I gained lots of clinical experience. I found lots of great cardiology mentors, and I kind of confirmed my career aspirations. I did lots of senior house officer jobs after that, including intensive care job and a renal job. But my cardiology job at that point was done at St Bart's Hospital, where again I found more great mentors, and I really learnt that I enjoyed cardiology research and that probably the academic path was also going to be important to me. I applied then for my cardiology training and went on to be accepted on the North West London Cardiology SPR rotation, so spent the next few years of my career predominantly going around various hospitals around North West London, and of course at that point getting my general and my subspeciality training. And I became an interventional cardiologist, so that's the cardiologist that puts stents and balloons into blocked arteries. I implant pacemakers, and some of us also work on structural aspects of the heart. So we are somewhere between medics and surgeons in terms of the kind of work that we do. As part of that training, I went off to Milan and did an interventional fellowship with a very famous cardiologist out there. And actually that really buys into my COVID-19 experience, because in fact the hospital that I was in Milan, San Raffaele, was in Lombardia, and it was one of the very, very badly hit hospitals when COVID-19 took hold in Italy. So I learned a lot about how we would adapt our pathways from what my colleagues were telling me over in Milan. I did my PhD at Imperial, and that's kind of compulsory if you want to get a teaching hospital cardiology job, but particularly, of course, if you want to become an academic. And now I'm an interventional cardiology consultant at Imperial NHS. I specialise in all sorts of coronary intervention, but also in imaging within the vessels of the heart, and also in performing various techniques to look at the blood supply to the heart. I'm a clinical academic, I'm a clinical trialist, and also importantly, half of my role is to be a senior lecturer at Imperial College, where I do lots of research and teach. So let's think about the good old days. So the good old days in cardiology were a bit like this. We do lots and lots of different operations. We do lots of clinical trials. I have gone all over the country doing various clinical trials and meeting all sorts of fantastic colleagues. We actually have a pretty intense career path in which we do lots of night shifts. We're on call from home, and it can be quite intensive, but actually predominantly it's really very fun. You can see that there aren't that many women in interventional cardiology, and actually we make up about 6% of interventional cardiology consultants in the UK, but that's changing and getting better and better all the time. But actually everyone I work with has been incredibly supportive as me, as a mum and a woman within interventional cardiology. Now, those were the good old days, but actually, as you've heard from Jamilah and from Chloe, things changed very, very rapidly for us at the end of February, beginning of March, as we suddenly realised that those good old days were hopefully not over forever, but paused for a little while, and that we had lots of new changes and challenges in our cardiology service. So what we realised was that we were about to have to learn all about a new disease, a disease that actually it affects the lungs predominantly, but actually it can affect many, many other organs, and seems to have various sequelae on the heart, particularly because, as you heard, it's a disorder that can cause lots of blood clotting disorders, and that can cause heart attacks, and that can also potentially cause heart muscle abnormalities. So we were about to see lots of cardiology that would be new and very different to us. In addition to that, we had lots of changes in our practice. So we knew that we were going to be doing, as you heard, the telephone clinics rather than face-to-face clinics, and that we were going to be operating very different rotas as we tried to deal with the extra workload. We also, importantly, had realised that we didn't know very much about this disease and that the evidence base was evolving. Now, in cardiology, we really love to think about research, we love to think about the evidence for what we do, and it was incredibly unsettling having no real evidence for what we were about to do next and how we were going to treat our patients. Importantly, we also had to think about staff protection because we do lots of procedures that involve us being at the head end of patients, obviously exposed to lots of bodily fluids, but importantly, also aerosol generating procedures, which we knew would be transmission sources potentially for COVID-19. So we had to think about protecting the staff, but also protecting patients, because we would have wards where there may potentially be undiagnosed COVID-19 patients on wards with patients who were COVID-free, and potentially some of those patients would catch it. And in addition to all of that, we had to think about a new command structure. So we're very used to multidisciplinary teams, lots of people being involved in any decisions that we make, and all of a sudden we were told that actually we were now the front line of a potential war zone, and that in this new command structure we had to be very much told what to do from a top-down approach in a command and control fashion, and that we had to be ready to just take those instructions on and go forward so that we could move rapidly. We very quickly had to adapt all of our systems, and in fact everything changed within weeks. So we had to have a new staff rota because of course we were very quickly exposed to staff sickness, and we were also found that many of our consultants who come to us from link hospitals at district general hospitals and might work at the Hammersmith Hospital for a day a week were suddenly repatriated to Ealing Hospital or Northwick Park or West Middlesex, where they were incredibly overwhelmed by COVID-19. So we were suddenly manning the rota with half the number of staff, and we were also having to cover each other's illnesses. We had to deal with new cardiac arrest protocols because, of course, before we could consider cardiopulmonary resuscitation on patients who'd arrested, we had to make sure we were protected. We had new London Ambulance Service protocols because, again, the ambulance service was overwhelmed and had to deal with new pathways to try and get cardiac patients to us as quickly as possible, and also make sure that they dealt with the COVID-19 patients that were flooding into the hospitals. We ourselves got some respiratory and ITU training because, of course, this was a new disease and we had to get some new skills. We developed new pathways for our heart attack patients because, again, we needed somehow to separate COVID patients from non-COVID patients. We had to get lots of PPE, so protective equipment, in for all of our patient contact moments. And we developed new places in our hospitals so that we could separate the COVID-19 patients. So we had red operating theatres where we don't operate on COVID patients, and red COVID wards where those patients would predominantly sit. We had lots of new challenges for our staff. So we suddenly found right at the beginning with lockdown that our staff were having problems getting into hospital, that they were having problems with accommodation because, of course, at the very beginning, as you might remember, we were told that if a member of your family was sick, you needed to isolate the whole family, even if you were a health worker. And so all of a sudden we lost lots of members of staff to sickness and amongst their spouses or their kids. So we needed to find accommodation for people so that they could continue to work and not have to isolate with their families. We had to think about the health of our staff, and many of them became sick, and around 30 to 40% of the staff in the cardiology department were sick at some stage, maybe with COVID, maybe not. We didn't always know because we didn't have the swabs at that stage. We had to think about food because, of course, all the supermarkets were suddenly very difficult to access, and at the very beginning of the outbreak, food at the hospital was also very difficult to access. Childcare was an issue because, of course, many of our staff have caring responsibilities, and suddenly their kids were off from school. And if one or more members of the family were working in the NHS or were key workers across the sector, we found that they suddenly had problems trying to find childcare. And of course, importantly, we had to think about the psychological and mental well-being of our staff, which was massively challenged as things changed so quickly for all of us. So I can show you that my life changed incredibly rapidly. So all those fun pictures of us hanging around the cath lab with music playing in the background, which is our kind of normal thing, had changed. I had to learn how to put on PPE. I had to learn how to operate in goggles and a visor and a mask, which was very hot, very sweaty. Sometimes you could barely see through the goggles, and it was incredibly oppressive at times. And of course, at that stage, we were worried for our own risks because we weren't really sure how likely it was that we might contract the disease, and that was scary and stressful. We, in order to deal with some of these stresses, actually did something that we do a lot of at Imperial, which is simulation training. So at the very beginning, what we did was get a mannequin and simulate various COVID-19 situations in our cath lab so that we could learn what went well and what didn't go well. So very quickly, we realized that it was really hard to communicate in all of this gear. It was really hard to work out who was the surgeon and who was the anaesthetist and who was the nurse. So we needed to work out ways to work to identify each other. We worked out that we needed to put our names on our visors. We needed to wear slightly different kits so that we could identify each other, especially when things were stressful. We also worked out that in the COVID operating theatre, it was very hard to communicate with the outside world if there was kit that we needed that wasn't available in the theatre. So in those first few weeks, we set up communication pathways with the outside, and all of this we learned from doing lots of simulation, which has been fantastic in terms of getting us up to speed. Now, in terms of our staff experience, well, we did see lots of sickness in the workforce, and that was really sad. Luckily, in our department, we didn't lose any lives, but we certainly have lost lives in the hospital and in the wider trust, and that's been incredibly sad for all of us. We had lots of staff in self-isolation at various points, so we needed to send them food and help them and keep their morale up, because of course, if we lose our staff to morale and stress, then we were doomed. So we knew we had to keep that up and keep the team mentality as strong as possible. Many of our staff had real difficulties shopping for food at the beginning, so we did deliveries for them. As I said, there was problems with transport, and most importantly for many of our staff, their staff leave was cancelled. So people were incredibly tired, and now many months on, we've only just started to be able to have our leave, and that's going to be incredibly important for us. So how we approached our various staffing issues was that we really had to adapt, and as Jamilah said to you earlier, we learned to work much better as a team than we've ever done before. We met members of the team very regularly. I was in charge of staff support, so I had to get very good at asking every member of the team how they were doing, more than just saying hello in the morning and get you a cup of coffee, but really care about their wider lives. We set up a support group that was representative in the entire team, and we had nurses and physios and technicians all within that team, porters, so that we could all talk to each other and work out what the particular stresses were for each of the particular sections of our department. And importantly, we had to find time to have these new roles, and sometimes it had to be in our extra time, so it was sometimes quite tiring. Most importantly, I felt that we needed to respond and react to immediate issues, because we sometimes felt that the wider the government response, etc., was a bit slow, and we had to be quick because our staff were at risk, and we needed to try and act as quickly as we possibly could. Most importantly, we had a targeted and constructive approach to most of our actions. We did lots of staff fundraising because actually we needed funds immediately for food and taxis, and actually PPE. We spent over £20,000 in our department on our own protective equipment when it was hard to get that from the wider sources. We had to find hotels for our staff, we got radios for the wards, we got temporary beds for our staff, and importantly we also bought iPads for the patients so that they could communicate with home. And all of that fundraising was really just through friends and family and a kind of crisis fund that we set up. Now, there were some unexpected wider implications from COVID. One of the things we really were not expecting was that the number of people presenting with heart attacks significantly dropped by 50% across the country, and we saw this almost immediately as lockdown started. That was a real worry because, of course, heart attacks aren't something you can hide, not usually something you can deal with at home on your own with some medication. So we very much are expecting that there will be wider implications in terms of cardiovascular health for our community. We found since then that we've now got a backlog of outpatient appointments and tests that need to be done because many things were suspended during COVID. We now have much longer waiting times, unfortunately, for lots of our elective procedures and tests. And we have found that despite everything that's gone on, and despite the fact that many patients have waited for a long time, they're now incredibly concerned about attending hospital and often cancel tests or appointments because they're worried about the threat to their own risk, to their own lives if they were to come into hospital and contract COVID. So we've had to really try and set up some support networks for that. We've seen lots of patients present with very late with cardiac conditions, and that's obviously a worry for us as we see young patients who probably sat out heart attacks for many weeks and have now come in with complications as a result. We're certainly, I think, going to see higher cardiovascular mortality and morbidity rates because of the impact of what's happened over the last few months, but we're trying our best now to catch up. We are now trying to develop new COVID protected pathways so that we can support those patients who absolutely want to make sure that they are at the lowest possible risk of contracting COVID when they come into the hospital for their various tests. And so we've got new pathways that make sure that they come in through special entrances and go out through special exits, do not interact with the rest of the hospital, and importantly are swabbed before they come into those areas so that everyone in those areas is negative. And we've also seen a great impact on our non-COVID clinical research because much of that was suspended, and we're now trying to get all of that back up and running because, of course, so much of that research is really important to the wider cardiovascular health of our community. So just to finally end, much as the other ladies have, on a positive note, I think every cloud really does have a silver lining. We've seen some fantastic positives as a result of COVID. So importantly, we've really got to know each other as staff. And although at the very beginning we were finding it really difficult to access food and transport, etc., really very quickly the public stepped up in a way that was so heartwarming and kind of brings tears to the eyes when I look back at these old photos. The donations came in so fast that at times I was kind of sick of eating cake and donuts. People didn't stop offering us food. The black cab drivers across London helped us with free cabs and deliveries of PPE across our hospitals. It was amazing to see how much people appreciated what we were doing and how much they appreciated the NHS. And importantly, and this is the last slide, I'll leave on a personal note. Mm-hmm. So in my family, I have a young 9-year-old son. My husband's job has really always taken the primary role in our family, despite the fact that I was working hard as a cardiologist. And I think in my son's mind, my job was a bit part-time. But actually, as my husband ended up working from home and doing all the pickups and drop-offs and doing all of the support at home, they sat at home and baked cakes and thought about the NHS and drew pictures about the NHS. And suddenly my son really started to appreciate what I did. And you can see a cartoon that he did at school a few months ago, the journeys of his mum as she snipped and buzzed in the cath lab theatres. So I would end on a really positive note, which is that in my own family, there really is much more of a work-life balance and a split between the roles between me and my husband. And I guess a wider appreciation of what I do as a mum and what I do obviously at work, and that's been fantastic for me personally. And I'll stop there.
Wow, that is really brilliant, Rasha. And yeah, I just have to say, I know that you were really driving a lot of that sort of fundraising and everything, and it was so critical to have any sort of sense of normality for your whole team. Yeah, and this whole thing that you mentioned at the end about obviously, you know, reflecting on you as a woman as a cardiologist. Yes, there aren't huge numbers of female cardiologists, and this is something that we're hoping will definitely, you know, change going forward. And we're all of us women here, we're all pushing for that. And I have to say, we all work as part of the National Heart and Lung Institute. And one of the great things about that institute in terms of the academic staff, so the professors like myself that are scientists, we now have 50% female scientists. So that is really fantastic. And we want to get to that point with our clinical scientists. So that's our sort of aim going forward. And you can see these are going to be our future professors. So it's all looking good. And you can see how these guys, you know, they're totally committed to their jobs, you know, working phenomenally hard and just, you know, doing fantastic work. And it really sort of shines through how, you know, incredibly hard you've worked throughout your whole careers, but also how rewarding that is. But there's clearly a lot of sacrifices on the way in terms of time that you have to devote to your career. And like you've obviously all, like Rasha sort of, you've obviously missed out. I know a lot of people are have been able to spend time with their, my stepdaughters have to spend probably too much time with her kids. it's changing times, and I think yes, it's thinking about the positives that we can also take from this. So Margarita, come give us some questions then. I'm sure we've got some from people that are listening.
Yes, we have some questions. At first, I want to say that I checked all the comments and posts, and some of them want to thank you for being our heroes these days. So that was really touching. And I have to mention that before I move on to the questions. So how is the situation in hospitals now, and how do you cope with the work-life balance?
Who's going to kick that off? Let's start with Jamilah. Put you on the spot.
Yeah, so I guess there's two questions there, aren't there? I think things are definitely much easier for two reasons. I think firstly, the numbers have gone down at the moment, so the amount of COVID we're seeing is much less. And so obviously that relieves some of the acute pressure on the hospitals. And I think the other reason things are a little bit easier maybe is because we've done a lot of learning in the past few months. It's been quite intense, things had to change very quickly, but I think we now recognise the disease much better and we understand it better. And we also have more of a feel of what our pathways are going to be as patients move through the system. And so that makes it easier. I think there are new challenges now in that as we reopen the systems to non-COVID care, we're having to integrate COVID patients and other patients. In the acute stages of things, it was just COVID, there was nothing else happening, whereas now we're having to run both systems in parallel, and I think organising that and developing capacity for that is really challenging. So things are better, but also sort of new challenges coming along. And I guess for me, in terms of work-life balance, I mean, again, it is better now than it was. I think there was a period where there was no work-life balance, but things are restoring themselves. And actually, I guess one of the things that I have learned personally is how important that is. I mean, I think you continue to learn that through your training, but actually I know that I'm less good as a doctor and less good as an academic if I'm not looking after myself. And I think being aware of when you're tired yourself and when you just need to take a step back is really important. And I guess I'm managing to make a bit more room for that now than perhaps I was a couple of months ago.
And are you able to, do you feel sort of confident communicating that with your, senior people that you're working for? Do you feel that that's more accepted now, that, you don't have to pretend to, just keep soldiering on?
Yeah, and I think it's been really interesting, and I think that's one of the best things we've learned actually is the NHS in this. I think often doctors are really bad at communicating when they're tired and vulnerable and when things at work have affected them personally, because of course they do. And we see suffering, we see great suffering and great joy all of the time, not just in COVID. But I think one of the things that we've gotten better at now, and this goes to what Rasha was saying really, is that we ask each other more how we're doing. We know each other better, and we're much more sensitive to other people's concerns or issues and what might be happening outside of work and how that affects them in work. I think people are more sensitive now than they were.
Yeah, and so when you're asking people, you actually, if somebody says it's not, they're not doing well, that's okay. That's
totally
sort of accepted as right. That's okay. We know, now that's great. You've told us, shared that with us, and what can we do to help? And okay, Rasha, anything to add, Rasha or Chloe, on that?
I think there was almost quite a simplicity to the COVID time. Because one of the things that I think has always been hard from a work-life balance point of view is you always felt the sense that if you had to work a weekend, you would work a weekend. If there was, you always had to be on hand, because otherwise, you were seen to be not working 110%. But actually in COVID times, it was kind of okay to say, on the weekend, this weekend I'm off, so if it's okay, I won't really be contactable. And it was almost actively encouraged because people said, well, you're doing double the number of shifts. So when you're away, don't be in the hospital, be at home and rest and see your family. And so there was definitely some aspects to it when you look back that were easier. For me personally, I usually travel quite a lot with my academic work, and so obviously that was entirely suspended. And maybe that, you know, allowed me more time to kind of focus on some of the other bits of my life.
Okay. Anything else, Chloe? It must have been very stressful for you having to have those conversations, as you know, all the time with you know, families that were, you know, very stressed and anxious about their loved ones. Yeah,
I mean, I have to say, I did find that it was really tough. Those days that you know, they were long days and they were very tough. But I was just interested to hear what Rasha was saying about in her family, because I found the same thing actually. Suddenly. There was slight role reversal of my husband was doing much more than before, because I just wasn't able to do it. And you know, that it's quite interesting that you were saying the same thing. And yeah, it was quite an eye-opener, you know, how our female roles do change with these large events that happen in time.
I think to say something that my 8-year-old said, he said, "Mummy, your job must be important, because when COVID happened, Daddy just had to stay at home and you kept having to go to work every day."
Yeah, that's great. Yeah, I like the way that they've elevated other people's jobs, you know, so, you know, to key workers. I love that term. And I think, you know, that because, yeah, lots of people do excellent jobs, whatever it is they're doing, you know, whether they're the porter or, like you say, those people that are making you food. That's really important, you know. And so I love that term. I think that's also been a very positive thing. Yeah. Right, Margarita, another question? Oh
yes, there is another one. I want the opinion of Chloe, because she mentioned that on March 19th, the government decided to move elderly patients into care homes, even if they had COVID-19. Do you think this caused more stress on the NHS or less? And how you deal with it?
Very big question.
I'm not sure I did speak about this, did I?
No, I mean, I'm sorry, but you said that you try ways to help and, you know, support the COVID-19 patients. So do you think that the elderly people needed more support than the rest of the age groups?
The elderly people?
Mm-hmm.
Yeah, yes. I mean, most definitely, you know, the biggest risk factor for COVID-19 is age, beyond everything else. So, yeah, without a doubt, that they do need support. And this has been one of the hardest things, you know, when you're speaking to these people on the phone in clinics, you know, and a lot of them are living on their own, you know, and they have got support and they have got someone coming doing shopping. But actually, interestingly, I'm finding that the clinics are often taking longer, not necessarily talking about their respiratory problems, but talking about how they're coping and how they're managing with the current situation, and you know, their mental health, their physical health, because you know the government says go for a walk, and some of them do try to do that, but some of these patients that we're caring for aren't able to just easily get down some stairs and go for a walk on their own. You know, before they would have had family support, and you know, they may not be seeing their families, and it's incredibly tough on them. But equally, I've been amazed at how stoical most of the patients are. That they are incredible, and feels a real privilege to talk to them, and particularly the older ones. Yeah.
Okay. Anything else, Margarita?
I have a question. Were you afraid at some point that something may be wrong, that maybe get COVID-19 and something, you know, and bad?
How do you mean, Margarita? Explain.
I mean, yeah, I'm not quite sure how to explain it, but we are human beings and we are afraid sometimes. But when you are in the front line, you don't have time to react and to think that I have to protect myself. But I know from other clinicians from Greece that at some point they were really scared because it was unknown what was going on with the virus. So I would like to ask our invited speakers how they deal with that, how they deal with themselves. Were they afraid of the unknown? And what is the next about it?
You know, I think that's such a good question. I actually think, looking back, I was much more scared than I actually realised. One of the things we noticed in the first few weeks is we were all saying none of us could sleep, and if we all look back on that time, there was very confusing guidance. So we weren't sure, you know, we weren't wearing masks in the hospital. We weren't really told how much PPE was appropriate. And a lot of us got very fearful. People were getting sick and we didn't know if it was COVID or not because we didn't have swabs, and that was starting to worry us. We'd heard that many healthcare professionals in Italy and in China had died, and people were really worried about that. Personally, what happened is that I got very concerned for the rest of the family. So many of us, and I've heard from lots of doctors, you would come in, strip off, not say hello to anyone, go straight up for a shower, and then come down to see your family. And I think it can't really be underestimated how scary that was for us and our families, because actually, when many of my friends were told to keep themselves indoors, keep their families safe, we weren't really asked if we were happy to still get into our cars and keep on working. Of course, we were happy, but I think there's a psychological impact to that we're probably still kind of living with now.
Yeah, I mean, they have talked, haven't they, about both patients and hospital workers having some sort of PTSD associated with this. I mean, we can't, underestimate the amount of stress for all round, I think, for so many people on so many levels. But, you know, I can't imagine for you guys. Yeah, incredible. And anybody else want to comment on that?
I guess for me, I wonder whether even in normal times, we see people who are very similar to ourselves or very similar to our parents or our brothers and sisters, our kids, getting unwell in hospital, even outside of COVID times. And I think we're only human and we all must absorb that to some degree. And I think we as a profession need to be better at acknowledging that happens to us every day at work, and recognizing that and talking about that. And I think maybe one of the things that has happened in the past few months is it's been a much more vivid example of that sort of fear and that sort of interaction with your own mortality, really, and your own vulnerability. And I think I mean, it is interesting, this question, because you, as you know, anybody that is a doctor must have a certain level of emotional resilience, a way of coping with this. I mean, I know for me personally, I get very upset if I see somebody that's ill, you know, anybody that's ill. I just find it really, really upsetting. So, yeah, I just, you must have a certain quality to be able to deal with that situation. And also I'm just thinking, what, you know, we always ask people when they're being interviewed for medical school, you know, how would they cope with stress? So I'm just interested in how you sort of cope with that. How do you keep your sort of good mental health and well-being? Are there any sort of tips, techniques that you have used throughout your career?
I think in medicine there is choices you can make. So you can do roles that are less front facing towards illness, and I find people being unwell actually quite unsettling, and particularly when, you know, personal events have happened in your life. And then so I've made more choices now, being more honest with myself, that I do find it upsetting, and so taking on more roles that are where I'm still using my medical skills, they are still very much helping people, but just, you know, not necessarily dealing with those acutely unwell, because I'm very similar to you, Sarah. You know, it does upset me. That's not necessarily a coping. Well, it is. I guess it's a long-term coping strategy that I've realised in the last few years.
So that's interesting.
Yeah.
How about you guys, Rasha, Jamilah?
One of the things, I mean, because my work obviously involves operating on people having heart attacks a lot of the time. Sometimes it's in the middle of the night. Sometimes very, very horrible things happen. And actually, I don't think you ever totally normalize that. There's still times when, you know, you're fighting back tears. And that happened to me a few times in COVID, where I was breaking bad news over the phone or having, you know, very, very, very hard conversations. The one thing I've always said to people I've taught and people around me is that we should never forget what a privilege it is, because in fact, in those moments with those family members or with the patients, you get to know them very quickly in a deep way, in a very important moment in their lives, in the way that very few people ever get to. And I think if you do that well, even with the grief of that patient dying or whatever else may happen, there's something very nice about knowing that you might have made that moment a bit better for their family. And you can take some comfort from that. And especially if sometimes you see people do it very badly, and, you know, it's kind of a privilege not to, well, to try your best not to do it badly.
Yeah. I mean, I obviously, like everybody else, I've had family members and people in hospital, and you can't underestimate how important that sort of those conversations, that bedside manner, etc. is. Yeah. So, Jamilah, any other? What about your personal? Do you go home, do yoga or
So
mindfulness,
I guess
play the piano, or what's the trick?
I guess I do a mixture of this. I guess for me though, what both Chloe and Rasha said is really, really rings true. And I think in particular, the concept of being honest with yourself about how you're feeling is something that I think is really hard, but I think it's something that you learn over time through your training and your practice. You learn to recognize when things have affected you and when you are feeling emotionally like you just need a little bit of support. And so for me, when I recognize those moments, I guess I'm quite strict about leaving work at work. And kind of become even more clear about that when I'm not feeling, you know, so good about things. And make sure that when I'm at home, I'm not working and I am doing yoga or running or spending time outside or with friends and family, and also making sure that I talk to people about how I'm feeling. But I think it starts with that kind of being honest about how you are.
I think that's brilliant. And I think that's one of the things that we need to sort of train our medical students more, you know, get them sort of in that sort of way of, because, you know, they're in training with hundreds of other medical students and way of opening up and talking about how they feel. It's really important, isn't it? I mean, I know it always used to be a thing of, you know, you shouldn't do that at work, but I think we recognize now that has bad consequences. So anyway, we're going way over, but I just wanted to mention, one of you had a picture of the British Lung Foundation, and I really wanted to put a sort of note out for the British Lung Foundation. I'm sure everybody has heard of the British Heart Foundation, which is a fantastic charity, supports a lot of research, a lot of clinical trials, and also, you know, supports patients in lots of different ways. And it's a huge charity. Now, in contrast, the British Lung Foundation is one of the tiniest charities in the UK in terms of the medical charities. And the reason historically is that people have always associated lung disease with a lot of the times with smoking. And so they sort of assume that, OK, if you've got lung disease, it's because you've smoked. If you've got lung cancer, it's because you've smoked. Well, look, we've had COVID-19. None of these people are dying because they've smoked. It's because of a virus. And, you know, for us to deal better with viruses like this and other respiratory conditions, we need to be putting the same amount of effort in our research and patient care in terms of respiratory disease. Now, at the moment, we're not able to do that because the British Lung Foundation is a tiny, tiny charity. Please, my one big thing would be, if you want to do something, you know, to support COVID-19 going forward, then, you know, do something to support the British Lung Foundation. I know that's a bit of a plug. I've got no relationship to the British Lung Foundation, and they've never funded any of my research. So, you know, I'm just putting it out there, but I do feel quite strongly about that. And what would you guys say, you know, in terms of the public, what would you like to see people doing? You know, wearing a face mask, what do you think is the most important thing going forward from here?
Gosh.
Anything particular that you think, you know, if there are people watching this thinking, what could we do? What should we volunteer? Should we raise funds for something? You know, how can we help? Because there are people at home thinking, you know, you guys, I mean, I know it's a huge amount of work, but as you say, it's almost a privilege to be in that position, to actually be able to be the people at the front line and responding to this and doing this fantastic work. Is there any other ways you think people could help?
I mean, people, certainly in my local community, everyone has been really supportive. You know, we've all been helping each other, and you know, the going out and clapping, and you know, that's been a huge big thing. People have, you know, my neighbours have got a band. They go out with their band, and the whole street sort of.
Yeah, we've got a local drummer.
Yeah, that's been incredible, and just feeling that, as Jamilah said, you know, that everyone's really supportive of the NHS and key workers. It's really nice, really nice. And I think how, you know, just little things like making sure your neighbour's okay. You know, if you've got an elderly neighbour, making sure they're okay, and also, you know, making sure that you're okay, because the healthier the population is, the less they need the NHS. So, you know, like I mentioned with asthma and respiratory diseases, people really looked after their own condition, and that's made a big impact. That's helped hugely with the NHS.
Yeah,
so I think that's really important.
It's also important to tell everyone that we are open for business.
Yeah.
And if they are sick and they need us, we are here, and we will do our best to, you know, reduce their risk of catching COVID in the hospitals, etc. That's a message that must go out now, because one of the hardest things to see is these late presenting, Chloe talked about it as well, patients who you wish had just come to us a few weeks earlier. So yeah, just keep looking after yourselves, and you know, come and find us if you need us.
Great. Well, that is brilliant. I mean, thank you so much. I mean, this has been really insightful, and yeah, obviously we all know that doing medicine, fantastic, really worthwhile, incredibly rewarding career. So yeah, I'd just like to say thank you for your time today to Jamilah, Chloe and Rasha. And thank you, Margarita, for moderating the question, and Sam for producing the session. So tomorrow is going to be our final Imperial COVID-19 lockdown lesson. It will be at 2 o'clock. We will be talking to James Kinross, another doctor, about how they have adapted the Microsoft HoloLens technology to use during lockdown. So HoloLens is a hands-free and can be used while wearing PPE, and it's a type of, well, it has telemedicine capabilities, allowing doctors to keep on treating very ill patients while limiting their exposure to COVID-19, and obviously thereby it reduces the rates of infection between staff and patients and within hospitals. So this is obviously another cutting edge technology, and will be super exciting to hear about that. Just before we go, please check out the link to the survey in the chats, and please fill out that survey. It would be great to hear about what you thought about this session. Enjoy the rest of your day, and hope to catch up with you tomorrow. So goodbye from all of us. Thank you.